bite-sized seminar is part 2 in our series Introducing Dry Eye, brought to you by the Alcon Experience Academy. And we will be looking at clinical diagnosis, what and how you do this. My name is Karen, I'm a Practice Development Manager for Alcon. This session is based on the TFOS Juice 2 report, which is available from the Tear Film and Ocular Surface Society, TFOS, at their website www.tearfilm.org, as found by the subcommittee looking at diagnostic methodology. So first we should consider the purpose of the diagnosis. For the patient, this gives a name to their condition, which can be treated. For the eye care practitioner, it gives consistency. Dry eye is a subset of ocular surface disease, so the symptoms are as a result of the condition. For diagnosis of dry eye, signs and symptoms must be present. So how is dry eye diagnosed? So TFOS Juice 2 report recommends a number of tests for diagnosing dry eye and the assessment of its severity. The TFOS Juice 2 Diagnostic Committee looked at numerous tests which we should be able to perform in clinical practice to be able to diagnose rather than refer. Tests that could be done least invasively, and they looked at the smallest number of tests that could be used to diagnose. First, we have the triaging questions to rule out other diagnoses relating to ocular symptoms. So to name a few: how severe is your eye discomfort? Is your vision affected? Does it clear on blinking? Are the symptoms much worse in one eye than in the other eye? This is followed by the risk factors, looking at non-modifiable factors, the ones we can't change, and modifiable factors which we can. Each of these factors have 3 categories, which are consistent, probable, inconclusive, as shown in the table. So for example, age, female gender, Asian race are non-modifiable and consistent. Computer use and environment are examples of modifiable and consistent risks. Diabetes would be an example of non-modifiable risk that has a probable impact on the likelihood of dry eye. But you may be surprised that while smoking and alcohol are examples of modifiable risks, they are reported as inconclusive. Diagnosis then requires confirmation of symptoms using one of the 2 specific symptom questionnaires, identified as being most reliable for screening dry eye symptomology. You need to pick which one you would like to adopt in practice and then consistently use this. The Dry Eye Questionnaire 5, or DEQ 5, after this has been completed, the score needs to be equal to or higher than 6 to confirm presence of symptoms of dry eye. And it looks at how the patient's eyes felt over the last month. Ocular Surface Disease Index 12, or OSDI 12, and with this questionnaire, score needs to be equal to or higher than 13, getting the patient to score how their eyes felt over the last week. So once a positive symptomology score has been established, we then need to confirm at least one positive clinical sign indicating dry eye disease. So these are known as homeostasis markers. We're looking at reduced non-invasive tear breakup time, elevated osmolarity or a difference in reading between eyes, or ocular surface staining. So let us look at tear breakup time or tear film stability. Non-invasive tear breakup time can be measured with slit lamp Myers, keratometer Myers, or tools like Tearscope and Topographus with the appropriate software. If no other tools are available, fluorescent can be used, but this would be invasive. Dry eye is indicated if tear breakup time is less than 10 seconds using a stopwatch or a timer on equipment if available, rather than counting in your head 1 elephant, 2 Mississippi. This is to be encouraged so that we are consistent from measurement to measurement and practitioner to practitioner. Osmolarity is measured with equipment like TearLab or an eye pen. If the measurements are equal to or above 308 osmoles per liter, or there is a difference of 8 osmoles per liter between the 2 eyes, again this is an indication of dry eye. Ocular surface staining. We will be using lissamine green or fluorescein, and this needs to be done after measuring non-invasive tear breakup time. We're looking at corneal punctate spots, seen with fluorescein, blue light and yellow retin filter. If there's more than 5 spots, this indicates dry eye. Lissamine green, seen with white and red light, and the conjunctival spots counting more than 9, and at the same time checking the lid margin at Mark's line if the staining is 2 mm in length or 25% in width. Again, this is an indication for dry eye. So we recently have had notification from the General Optical Council that lissamine green can be used if CE marked when necessary in the patient's best interest within the scope of practice. Fluorescein and lissamine green should be installed at the outer canthus to avoid ocular surface interaction and could be checked at the same time. Once one of the homeostasis markers has given us a positive result for dry eye disease, we can move on to the subtype classification to establish aqueous deficient dry eye or evaporative dry eye. So we're looking at tear meniscus height, which is measured with a topographer or a slit lamp, which you set up using the size of slit to check the height. If this is less than 0.2, this will indicate aqueous deficient dry eye. Schirmer test or phenol red test can also be used, but are more invasive. Then we're looking at the meibomium glands and the quality of the meibum, ranging from clear meibum to cloudy and how easy it is to express the glands. And the consistency, so for example if it's cloudy toothpaste, this would indicate evaporative dry eye. Expression can be aided by cotton buds or tools like forceps. So at the moment there is no grading scale for meibum quality, so we're looking at clear, cloudy toothpaste, although an outline of one has been proposed by TFOS. Secretion of 4 to 7 meibomium glands, expressibility of 1, would indicate mild meibomium gland dysfunction. A high percentage of patients are likely to suffer mixed dry eye, which will be indicated by a low tear meniscus height and meibomium gland dysfunction. In summary, the pathway recommended by TFOS JUICE-2 will give a clear and consistent diagnosis of aqueous deficient dry eye, evaporative dry eye or mixed dry eye disease, which we as eye care practitioners will be able to do in practice, give the patient a right treatment plan without referral. In the next bite-sized seminar, we're going to be looking at management of dry eye disease. Would you set up a dry eye clinic or would you make it part of your site test? If you have any further questions or you would like more information, then please contact your Alcon Business Development Manager or a member of our customer service team. This was brought to you by the Alcon Experience Academy and forms part of our dry eye online seminars. And we thank you for watching.